So welcome to Grand Rounds for the end of the academic year. It's always bittersweet to reach the end of the academic year. Today we're going to feature 4 residents who will be talking about their own research. So one of the special things about our program here is that residents do have some time and some support through the Mentors in Medicine program to conduct their own research. And we'll be hearing from 4 of them today. You'll see the 4 names listed here. I'll introduce each one. None of them has a conflict of interest. The program that supports these efforts is called Mentors in Medicine. Mentors in Medicine in the broader area of CSTAR, a teaching program, a leadership program, and a global health program, was started about 2 decades ago here at Barnes-Jewish Hospital. The program has evolved. We now give grants up to $5,500 per resident. We have 2 cycles per year, so if you're thinking about a good research project, please do apply at the next cycle. Deadline's December 1st. So our first talk is going to be by Vinathi Polamraju, and she'll be talking about the clinical outcomes of COVID-19 infection in liver transplant patients based on vaccination status. Vinathi? Let me get you.
Good morning, everyone. I hope everyone can hear me fine. Thanks, Dr. Gage. I have a couple people to thank on this slide, Dr. Crippen, Dr. Chapman, Dr. Vaccination for all the statistical help with the study. But like Dr. Gage mentioned, my study was looking at clinical outcomes of COVID-19 infection in liver transplant patients based on vaccination status. And this was a propensity score matched analysis. It's advancing here, but not there.
So we need a little help syncing here, because the slides are advancing on the terminal.
The giant first.
So taking us all on a flashback to the COVID-19 pandemic and the advent of vaccine development, in December of 2020 was when the first vaccine became available on an emergency basis, but it wasn't until January of 2022 when over 3 billion doses were available globally, and that's when we started seeing an overall downtrend in COVID-19 mortality. But if you look at the early COVID-19 vaccine trials, particularly the ones that were available here in the United States, they all had one thing in common in that they failed to include those on immunosuppressive therapies or those with immunocompromising conditions, which really begs the question, do these vaccines even work for such patient populations? And one particular cohort of these patients are liver transplant recipients, and the early clinical outcomes of COVID-19 infection in liver transplant patients were largely international and observational studies. And I highlight a few here. The first is this Italian prospective double center study. This was published in 2022. And in their conclusions, they note that liver transplant patients actually weren't at an increased risk of infection, mortality, or hospitalization. But around the same time came this other study in the Journal of Hepatology that reported in Spain of 111 liver transplant patients that their chronic immunosuppression didn't increase disease severity, but actually increase the risk of acquiring COVID-19. And then came this multi-center European study looking at 342 patients across 34 centers in 9 countries, and they note that 25% of their hospitalized patients had actually died, the risk higher in those who are older and with other medical comorbidities. So even amongst a similar geographic region, you can see that there was contradictory data as to whether liver transplant patients actually fared poor or not so bad from COVID-19 infection. And Then you wonder, do these vaccines even really work for these patients? And alongside all of this clinical research came basic science studies looking at the humoral responses against vaccination for liver transplant patients. The first is actually a meta-analysis that was published looking at seroconversion rates for all solid organ transplant recipients, and they noted after the first and second mRNA-based vaccine, all solid organ transplant recipients, including liver transplant patients, had suboptimal rates. And this paper looked specifically at liver transplant recipients and measured antibody titers following mRNA-based vaccine doses and noted a substantial increase only after a third vaccine dose. The same study looked at factors that could predict antibody responses, and one specific factor that they isolated was chronic kidney disease that they defined as a GFR less than or equal to 60. And amongst all vaccine doses and time periods, they noted a reduced antibody titer level, which makes us wonder whether this antibody response has any clinical correlation and will more vaccines make a difference. Which brings me to the question I was hoping to answer with this study is, are mortality and hospitalization rates lower for liver transplant patients who have 3 or more, or any number of COVID-19 vaccines at the time of infection, and are there specific patient risk factors like chronic kidney disease that increase or decrease this risk? So this was a single-center retrospective study, and out of amongst about 1,800 registered liver transplant recipients, we identified 361 with PCR-confirmed COVID-19 from March of 2020 to July of 2023. These were all adult patients. We excluded those who reported self-positive home tests or didn't have complete data in our medical record system. 136 of our patients were unvaccinated, and 225 had at least one COVID-19 vaccine. So looking at patient demographics, out of our total cohort, the median age was around 64, with an approximate 42 to 58% female to male ratio. Over 90% were Caucasian. Most of our patients were overweight based on BMI, and in terms of comorbidities, 37% had diabetes, about 60% had hypertension, and 47% had chronic kidney disease that we had defined as a GFR less than or equal to 60. And only about 16% were within 2 years of transplant, the most common reasons being hepatocellular carcinoma, alcohol-related cirrhosis, and NASH or MAFLD-related cirrhosis. And more than 50% were on either dual or triple immunosuppressive therapies at the time of their infection. And I highlighted age and gender to point out that amongst all the variables that we just discussed, these were the only 2 that were significantly different between our vaccinated and unvaccinated cohorts, and the rest were not statistically different. Looking at vaccine characteristics for the 225 who were vaccinated, about 44% received 1 or 2 doses, and 56% received 3 or more. And the most common type of vaccine was an mRNA-based vaccine in over 90% of our patients, either Pfizer or Moderna, and only 6% had viral vector-based vaccines like Johnson & Johnson. So getting into the analysis, like I mentioned, we did 1-to-1 propensity score matching, calculating propensity scores for each patient and matching them to really determine the effectiveness of each vaccine. So 126 unvaccinated liver transplant recipients were matched exactly to 126 vaccinated patients, and we ran logistic regression analyses generating the following tables. And just to orient everyone to the layout, in terms of variables that we used, age, male when compared to female, comorbidities including diabetes, hypertension, and chronic kidney disease, and then comparing our unvaccinated patients to those who either had 1 or 2 vaccine doses or those with 3 or more vaccine doses. And first, looking at factors associated with mortality in our matched COVID-19 positive liver transplant recipients, having 3 or more vaccine doses when compared to their unvaccinated counterparts actually was associated with lower mortality rates. This depicted in a Kaplan-Meier survival curve, looking at 60-day survival outcomes. Those with 3 or more vaccine doses had a higher probability of survival when compared to those with fewer. And then looking at factors associated with hospitalization for our matched infected liver transplant patients. older age and having comorbid chronic kidney disease was associated with higher hospitalization rates. But vaccination status prior to infection actually did not impact hospitalization. So in order to determine whether age and comorbid chronic kidney disease held true for the vaccinated patients as well, we conducted another subset analysis looking only at factors associated with hospitalization amongst our vaccinated data set. And similar to prior, we see that vaccination status, again, didn't impact hospitalization rates. Older age, again, was associated with higher hospitalization rates. But comorbid chronic kidney disease now, interestingly, is not associated with higher hospitalization rates for vaccinated COVID-19 infected transplant patients. So coming to the conclusions, number one, that 3 or more COVID-19 vaccines was associated with lower 60-day mortality rates, but did not impact hospitalization. That older age increases the likelihood of hospitalization amongst our infected liver transplant recipients, and comorbid chronic kidney disease also increased this risk, but perhaps vaccination plays a more protective role than initially thought, based on this study noting suboptimal antibody titer levels. But obviously, more needs to be done. Which brings me to the critique of my study, the strengths of which, looking at both the pre and post-vaccine eras for this study, in terms of the duration of when the study was conducted, we were able to look at both unvaccinated patients and those who were infected around the time when vaccines were first developed and when booster doses were also available. Looking at multiple variables and being able to focus specifically on a small cohort of liver transplant patients provided for a very specific study. In terms of limitations, I think the most important one is the fact that we didn't account for evolution in the virus variants, looking at the different strains and how they evolved over the duration of the time period. We also didn't specifically analyze breakthrough infections. We assumed that each patient who was involved in the study had an initial infection of COVID-19, and this wasn't a repeat infection to our knowledge at least. Being a retrospective, single-center study, we were working with a limited patient population and potentially missed patients who didn't receive care or evaluation at our specific institution. And of course, didn't account for exposure risk factors or differences in health behavior for these patients. But I hope I was able to answer the question of whether COVID-19 vaccines really work for transplant patients, and that they do. But in terms of future directions, we're working on trying to compare hospital outcomes, determining whether certain medications or therapies result in a favorable course for our liver transplant patients, and trying to add additional statistics to look at whether the year of infection is important in terms of mortality and hospitalization. But I think taking a step back and looking more broadly, we need larger prospective trials to determine the long-term immunogenicity of these vaccines and to be able to apply our conclusions to other immunocompromised patient populations. So thank you.
Michael Kwok. His title is The Performance of Cardiovascular Risk Prediction Model Among People Living with Human Immunodeficiency Virus, Systematic Review, and Meta-Analysis.
All right. Thank you, Dr. Gage. It's a pleasure being here and talking with you guys. This project was actually originated from Brown, where I did medical school, and unfortunately my mentor can't be here today. He's the PI at Brown, a cardiologist. I think the premise of this project is that we all use cardiovascular disease risk score models in clinic, for example. We try and estimate their risk for developing such disease. And the goal of this project is a specific subpopulation of patients with HIV and how they perform, which I'll get into. So just some disclosures. I was fortunate enough to present this project at ACC this year. This is an update for the project. So I originally published it at Brown and as a medical student, so this is the update variant. But the original publication went through to JAMA Cardiology. And so I like talking about this because, cardiovascular disease, I'm interested in cardiology. And so antiretroviral therapy for patients with HIV has gotten pretty good in terms of alleviating the infectious burden. But now they're starting to see the consequences, unfortunately, of non-communicable diseases like cardiovascular disease, malignancy, even psychiatric diseases as the leading cause of mortality. So it's well known that these patients have an increased risk, some as high as twofold for developing like an MI, heart failure, sudden death. But what actually was really interesting for me was that these patients developed it at a lot younger of an age, right? Almost about a decade earlier. And so, they're at an increased rate and risk. They're developing a lot younger. I think the primary focus for these patients should be primary prevention, right? We use the risk score models to kind of stratify them. Where do they fall in terms of their risk? And then kind of what do we do about it, right? We have imaging modalities, and then we have, of course, medicinal components as well, which I'll briefly talk about at the end of this project. So the issue and where this project kind of comes into focus is that the risk score models were built upon patients who are usually white, elderly, and male without HIV. And so the question becomes, are these common risk score models generalizable to a specific population of patients with HIV? And so that's the purpose of this particular project. And I think this risk score model here we all know and love and use in the CO, for example. This is the ACC-AHA pooled cohort equation. There's many different variants over the years, but they do collect variables such as like blood pressure, cholesterol, if they're smoking, if they've had diabetes, but at no point do they ask, do they have a diagnosis of HIV, right? That they don't really address that in this particular calculator. And so there's only one risk score model that I'm aware of that's widely used, and it's called the DAD. And this risk score model does, in fact, take into account HIV. It was predicated and built upon patients with HIV and take into account their cardiovascular disease risk. So we can see from the numbers of 7 through 10, they ask about ART exposure and they ask about CD4 count. And so the hypothesis would be that that particular risk score model would probably be best. But needless to say, we ran the meta-analysis trying to figure out the results. PubMed and MBase were searched from inception. That's July 1st of 2023. And for this meta-analysis, we ran a random effects model. We also did a fixed effects model, but they actually yielded similar results. So due to the fact that there's a decent amount of heterogeneity in our study, we decided to go ahead with the random effects model. And these are all the parameters that were included. But I think the inclusion criteria is very simple for us, right? There's only 4 things. They had to carry a diagnosis of HIV. They had to be greater than 18 years of age. They had to be, they had no prior cardiac disease prior to enrollment, and then they were followed, and there had to have been some sort of cardiac risk score model that was evaluated, and there had to have been some sort of cardiovascular disease outcome, right? There had to have been patients developing MI, and we were capturing that as well. So those are the 4 criteria, and it was a relatively easy way to narrow things down, and I just briefly want to touch upon the metrics. Like, how do we assess the performance of these risk score models, right? Like, what are we using to categorize them or stratify them? So the first is discrimination, and the second one is calibration. And discrimination is essentially how well a risk score model was able to put them in the high-risk category, for example, if a patient developed a heart attack, right? So if, like John, for example, he's 55, he's followed, gets an MI at 58, we look back and see the risk score models and say how well did that risk score model put them at the high-risk category. Calibration I like to categorize as like the OE ratio is very simple, like observed to expected. So the risk score models would have generate, for example, they predict 50 patients would get cardiovascular disease or an MI, for example, in 1,000 patients. And then we compare that to the observed, or the O portion of the OE ratio, which how many patients actually did in fact develop cardiovascular disease. And so you just compare the ratio and see how close that model was for predicting the real life outcome. The C statistic was the same as the C index for our purposes for the AROC, and we used the Strata software for stats. So the results, 820 studies were screened in this meta-analysis. 14 studies ended up being in the final bucket. This was an update about 50% from the prior publication that we had, which included only 9 studies. There's about 100,000 people with HIV that were included. The average age was about 42, 75% were male, and the average follow-up time was 5.8 years. I want to highlight that point because it's sort of a marker of the average age when they started, whether it be retrospective or prospective, was 42. And the average follow-up time was 5.8 years. And so I mentioned in the inclusion criteria there had to have been some sort of cardiovascular disease that resulted. So it probably would have captured more, but you could argue that 42 plus 5.8, they're putting these folks at 47.8 years of age on average, and a good amount of them were developing cardiovascular disease, and that's well known to be way younger than patients without HIV. They're developing typically cardiovascular disease in their 50s and 60s. So we are seeing that data pop up for us as well. These were the risk score models that were used. There are plenty more of them, but these are the ones that were just had a lot of data for. There's a lot of studies that created their own risk score model, but that wouldn't be very useful for a meta-analysis because that was an N of 1. But we know the pooled cohort equation, the ACC-AHA calculator that we all use. The DAD I mentioned, the last bullet point, that's the only one that involves patients with HIV. The Framingham risk score and the SCORE risk score model as well. So for discrimination, most of them had a moderate performance. We categorize that as anywhere between 0.7 and 0.8 in terms of the C statistic. The lower ones were the PC5 and the SCORE at 0.69 and 0.68. And then I'll go into the next slide, but we're seeing that the FRS5, the DAD 2010 and 2016 had the highest performance of discrimination. There was a lot of heterogeneity, in which I will talk about in this slide. We can see here that the bottom 3 risk score models, it's a little bit blurry, but they're at 0.79, 0.79, and 0.78. But we can see that there's such a big confidence, or a wide confidence interval in the DD 2010 and then the FRS5, which begs the question, like, do we really know where these risk score models land? My interpretation and what we published was that the DAD 2016 and the PC10, the one that we use in clinic at 0.78 and 0.74, would kind of be the most optimal. It has a much more narrow confidence interval. We kind of know where they stand. There's a lot of data for it. And I think it highlights the fact that even though we use that ACC model or risk score calculator in clinic, it doesn't perform too bad when it stacks up against the rest of the risk score models. So I think that's the take-home message that I got. And in terms of calibration here, I just wanted to highlight, so the DAD 2016, the OE ratio was 1.31, so it is under predicting risk. Anything closest to 1 is most optimal. We have the Framingham risk score at 10-year at 0.95, so it's arguably slightly over-predicting. And then we have, again, the PC 10-year, the ACC risk score model at 1.13. Right? It's the second closest to 1. And so I think these results, while it's not the best, we all are time crunched in clinic, and sometimes it's hard to bring about 3 different risk score models and calculate all of them for our patients. But I would say that it's certainly one that is appropriate to use within this specific population. So I kind of talk about the first bullet point, right? They had a moderate performance in discrimination. For calibration purposes, most of them under predicted risk between 20 and 50%. I wanted to talk a little bit about the second bullet point, right? Like, why are these patients developing cardiovascular disease a lot younger? Why do they have an increased risk? There's a bunch of hypotheses that have been floating around, like social determinants of health and how these patients are usually at a disadvantage. The chronic inflammatory state that's associated with HIV could be playing a role. But also the use of antiretroviral therapy, and this was before I practiced medicine or even got into medicine, but protease inhibitors, the earlier generations were well known to be linked to dyslipidemia. And so the very medications that we use sometimes are thought to be an increased driver. The integrase inhibitors now are more commonly used. There haven't been concrete studies that have suggested that it's associated with cardiovascular disease, but there have been some studies that try to account for confounders and have found maybe a correlation. And so I want to end this talk by trying to bring it back home and seeing how does this apply to us in internal medicine? How can we use this project? It's a very technical analysis, but what can we do with this information? So I think in primary prevention of these patients, you have a couple of different options. You have the risk score model component, you have like the imaging modality component, and then you have, of course, the medicinal component that we can do. The risk score model, I would argue that the ACC model is quite fine. The one that we all know and use and love is appropriate for this particular population. And then the other thing too, and this is not part of my project, but I thought I'd tack it on at the very end. At ACC this year, the REPRIEVE trial was pretty popular. It results in 2023. I believe it's some sort of sub-studies result in 2024. And this sort of speaks to the fact that, okay, so we have the risk score percentage for our patient. What do we do with that information? How does this kind of fit into like the guidelines? So this was a trial done with patients with HIV between the ages of 40 and 75. As an RCT, one arm got the placebo, and the other arm got atorvastatin 4 milligrams, and that was considered a moderate intensity statin. They followed them, and their primary outcome was MACE, or major adverse cardiovascular events. And they actually ended the trial early because they showed such a benefit for patients receiving the statin. And I mean, it's no surprise to us, but it's nice to see that we have concrete data for it. But at the end of the trial, after 5 years, they showed a 35% reduction after 5 years of MACE itself. And then the table here in the bottom right just shows the number needed to treat over 5 years, and especially the patients above 10%. And in terms of risk, calculated by the risk score model, the number needed to treat was only 35, right? And between 0 and 2.5 was 200, give or take. But regardless, they are showing such a benefit with statin use. And so this is like the cardiologist and the infectious disease coming together and providing these recommendations. Essentially, anyone between that falls, that is 40 years of age at least, and then between the age percentage of 5 and 20% in terms of their cardiovascular disease risk, they are recommending a moderate intensity statin. We can see atorvastatin 4, atorva 20, and rosuvastatin 10 all receive a pretty good, pretty high recommendation. Less than 40 years of age, there's not so much data for, and less than 5%, they're still favoring the initiation of a statin at this particular point, but the recommendation is a grade C1. And then, of course, the high-intensity statins, when their ASCV risk score is greater than 20% or their LDL is greater than 190, they do deserve a high-intensity statin. So I think I want to, again, if we don't take anything home from this study, I think the first thing is that very basically these patients are at increased risk for cardiovascular disease. They develop it a lot younger. I think if you were to pick a risk score model, arguably for crunch for time, the ACC AHA model is totally appropriate for these patients. And then the last thing is that I think we should be a little more cognizant for pushing for a statin in these particular patients, as it's shown such a big benefit. So this is the conclusion of my particular study, but yeah, I think those are the 3 bullet points that I want to present, and hopefully you guys can take home. Thank you.
Mike, thanks for a great presentation. The next talk will be by Dr. Justin Vincent. Does the HeartMate 3 risk score currently predict mortality? Justin?
All right. Thank you very much. So this study is something that I worked on with Dr. Vader, who's here, and also Dr. Lambert, one of our chiefs, as well as Elena, who's our statistician here, as well as folks at MGH, Ben Yang, who used to be here, but now is over there. So I just wanted to thank them all in advance. This study is in part a validation for the HeartMate 3 risk score in a real-world population, and with special attention to, does this currently have efficacy? Well, that's a bummer. I don't know where that went. Okay, all right. That was weird. All right, so basically, of all the LVADs out there right now, the current standard of care for left ventricular assist devices is the HeartMate 3. That is one that was brought onto the market early, like 2016, I would say, and the study that kind of showed that this was the latest and greatest LVAD, which was Momentum 3, also those same authors published a risk score to kind of give an idea of, if you were to implant this LVAD into a patient, will they have survival benefit based on different factors that make their patient case specific. And this is something that is used in advanced therapies evaluations as you're trying to work someone up. So one of the score itself was based on a multivariate analysis and has a bunch of different coefficients. And but the main point here is that it's a factor of both age, if you've had a prior open heart surgery like CABG or valve, lab values like sodium or BUN, and then some echo parameters such as the left ventricular end diastolic diameter, as well as a marker of right ventricular function, which is the right atrial pressure over the wedge pressure. And you plug all that in and it gets a score, and the idea is that whatever bucket you end up in should predict your mortality at 1 to 2 years. However, this score, like I said, was made when the initial HeartMate 3 study came out. Since then, UNOS, which is the United Network for Organ Sharing, who are the institution that kind of oversees everyone that's on the waiting list, and they're the ones that match the donors to the recipients. They noted that there was issues with waitlist mortality and organ distribution equity. So as a result, back in 2018 in October, they completely revised their allocation system. It used to be a 3-tier system, now it's a 6-tier system, and that was their goal. It was to reduce that mortality, increase the equity. One of the things that we've seen on a systemic level since then is that fewer patients are actually receiving LVADs, in this case HeartMate 3s, as bridges to transplant. So the score that was made before 2018 is still being used today as part of advanced therapies evaluation. So our question then is that basically, does the score accurately predict mortality for patients after the UNOS change? Our theory is that the population stratification is different. Maybe it's a different patient population that's eligible for an LVAD. So does the score still work, basically? So the way that we did this is that this was patients age 18 and over, both at Barnes and at Mass Gen, who received any type of LVAD between 2015 and 2022. We excluded anybody that had a HeartMate 2 or other types of VAD support, anyone that was currently in a clinical trial, and those that we just didn't have all the data to fit in for the actual score. And then that was pretty much it. We just put the score in and put in all their numbers and categorized them in the same buckets with the same score thresholds that the original paper used. So low is less than 2.41, high is greater than 2.97, medium is in the middle. So once we did that, we found that the primary outcome that we were looking at was exactly the same as the original paper. This was death or pump exchange, and we marched that out to 1 or 2 year follow-up. But for our case, we took our cohort and stratified it before and after the UNOS change. I'd like to thank Elena for all the statistical help. For categorical variables, we use chi-square test. For continuous, is t-test or Wilcoxon. And for the effect of the score on the time to our outcome was Kaplan-Meier curves and log rank test. So this is kind of an abridged version of our cohort. I'd like to say that it was a largely similar patient population to the Momentum 3 trial, which is about 660 patients. We have 242. 86 of those received their HeartMate 3 before October 18, 2018, and 156 after. For the most part, they're really pretty similar. They're about 60 years old, about 80% white, about 70% white, about 80% male, mostly non-ischemic cardiomyopathy. And of note, there was a pretty good chunk of them, about 35%, that were intermax 1 to 2, which is the highest form of clinical severity. So these were largely pretty ill individuals. Of note, of the variables that we calculated, only 2 were statistically significant between the 2 groups. And that was the folks after the change had a higher incidence of having a prior open heart surgery, as well as having that marker of the right ventricular function was a little worse after the UNOS change, and we'll talk a little more about that later. But taking that, plugging in their scores, we just wanted to use the same thing and try to first validate the score and also see if there's really any difference in survival based on how they actually ended up. So what we found is that before and after the change, there was a very large difference in terms of how the actual score predicted survival. Before the change, we saw really great discrimination. So low score folks survived more, high scoring folks survived less, and everyone else was in the middle if you're medium. And there's a nice separation between the curves. These are statistically significant, and it kind of leads to the same conclusion that the original paper had, which was if you have a low score, you can tell someone they're lower risk of dying. However, after the change, that kind of discrimination collapses. So it's not statistically significant anymore. You'll note that the low score is surviving worse, but also conversely, the high score appears like it's surviving better. And everything is crossing each other. And it kind of, from a clinical side, if you're saying you have this score, it doesn't necessarily tell someone how much risk they actually have of dying. And I just included the 1 year for kind of simplicity, but we saw the same trends at 2 year follow-up as well. So we want to figure out why that is. So we're just kind of spitballing here, but basically We do note that patients with LVADs are less likely to eventually be transplanted. Sometimes it's destination therapy, it's just there's longer on the waiting list. But when we were looking at that initial, I'll go back to it, why the low scoring patients were faring worse, our theory is that maybe there's just variables in this cohort that are not accounted for, different lab values or echo parameters or things like that that makes them not do as well, so that score goes down. But conversely, for the high score, our theory is that the people that were having the higher score actually surviving better is really more of an artifact, that the patients that are that high risk are likely too sick and artificially pulled out of the consideration for any type of VAD. There's limitations of this, of course. This is retrospective, only 2 centers. We really only focused on the score itself, not different surgical approaches or anything. And then to all say that this was due to the one date kind of excludes some unmeasured time-dependent changes, maybe different therapies, SGLT2 inhibitors were more on the market, things like that. But we did at least can kind of say that the date of the implementation was really one of the big changes. And then I mentioned that the right ventricular marker was the wedge pressure, right atrial pressure, wedge pressure ratio was statistically significant between the 2 groups. So we just wanted to see, does that mean that you can use HeartMate 3 risk score as kind of a proxy for right ventricular failure? However, with our cohort at least, we did not see a correlation between the 2. So, in conclusion, HeartMate 3, as it stands right now after the 2018 UNOS change, doesn't really predict mortality in those patients anymore, in those that are implanted with or changed to HeartMate 3. And really that just, for us, that means that the score needs to be recalibrated, revised, completely changed. Don't necessarily know how to approach that quite yet or who will do that, but I think the big picture is that still using that score now might have kind of overall impact on the advanced therapies evaluations, and it's just important to make sure that the scoring systems work now. So that's my references, and I'll come back to this, but I just wanted to thank co-authors, Dr. Vader, David, Ben, everyone at both groups, everyone in the internal medicine residency, and also the Mentors in Medicine program. So thank you very much. That is what I got. Thank you.
Thanks so much. The next talk by Dr. Scott Beeler is entitled Proteomic Signature Predicts Risk of Myeloid Neoplasia.
Perfect. Thank you, Dr. Gage, so much. I just kind of on the front end would really like to thank my mentor, Kelly Belton, who unfortunately couldn't be here today, but also kind of thank all of our co-authors, particularly Duke Tran, a tremendously talented data scientist I work with in the lab to really kind of help co-lead this project. Where's perfect? Grab is my answer. Perfect. Okay. So it's a very simple level. We all know cancer is caused by mutations, somatic mutations with aging. And so here, just a basic diagram. You have a healthy stem cell, can take whatever type of cancer. You develop somatic mutations and oncogenic drivers. Those increase kind of the fitness of the clone and lead to this kind of pre-malignant state. We take advantage of this in like colorectal cancer with identification of adenomas early and trying to prevent these cancers before you have a frank development and progression to malignancy, and this clonal expansion process that comes with the accumulation of subsequent mutations. For our study, we've really kind of focused in on the bone marrow and kind of really hematopoietic stem cells. There's been a lot of work over the past decade, but really we've realized that this initial first step, really the initial mutations in myeloid driver genes, leads to a state that's called clonal hematopoiesis. And it essentially just means that these mutations, these driver genes, gives these cells a fitness advantage. It leads to a slight increase in clonal expansion, which can be detected. We know this state of this initial precancerous state is it associated with increased risk of development of cytopenias as well as dysplasia, and then eventually subsequent development of myeloid neoplasms. Those would include, for our study, MPNs, myelodysplastic syndrome, as well as AML. And so overall, the past decade, there's been a lot of work. We know it's associated with worse overall survival, the state of clonal hematopoiesis, due in part to a small increased risk of these myeloid neoplasms, less than 1% a year. What's been really nice about this is, unlike solid organs like the pancreas, where it's really hard to detect these from a sampling perspective, we have a really great, the peripheral blood, we're able to really sample what the bone marrow is happening. And so we're able to really detect these off of kind of standard sequencing assays by looking for really low frequency mutations that are present in peripheral blood cells. And one thing that we've realized is it's really surprisingly common to have these oncogenic mutations that would be particularly worrisome, but they're very common with aging. At a kind of this VAF of 0.1%, which is like 1 in 1,000 cells, 70% of people by age 60 have that. So it's incredibly common, yet most people don't end up developing cancer. Over the past decade, there's been really a lot of work to understand. We have this window into really understanding the early and initial stages of carcinogenesis with this model, and can study it really well in lots of healthy individuals. So there's been a lot of work figuring out what are the risk factors for progression from CH to myeloid neoplasms. Really, the biggest driver would be aging. We know anti-cancer therapy plays a role, as well as germline mutations and DNA damage-related proteins, as well as a number of features specific about the mutations that we detect themselves. Certain genes like P53 cause more problems and are at higher risk. As the clones get bigger and you can detect more of those in the peripheral blood, the risk gets higher, as well as the development of cytopenias and certain morphology characteristics are all kind of a worse prognosis. And so there's been a lot of increasing identification of this state of CH with really the advent of kind of sequencing, especially in oncology. And so we're detecting this pretty commonly in individuals, and really knowing how to risk stratify has been really a big kind of push in the field. And so in the past year, there's been a couple scoring systems. One that's really been popular called the CHRS, or Clonal Hematopoiesis Risk Score, which has taken some of this research and tried to figure out how can we risk stratify which patients are most risk for progression to myeloid malignancy. And that data is here on the left. You can see the Kaplan-Meier plot. And so we can see overall in these groups of individuals, they're able to risk stratify this group in the top in the red that is at high risk for development. And so you can see at 10-year follow-up in the Kaplan-Meier curve, these individuals have a 52% risk of developing. Fortunately, that's only a small minority of individuals. In this study, that was only 1% of the individuals with CH. You can see that on the table. It was only 123 individuals out of almost 200,000 in that cohort, fortunately. And so overall, even though the low and the no CH, the cumulative incidence overall looks at the individual risk is very low. We still see most individuals, 77%, that develop a myeloid neoplasm actually come from these categories that have lower risk. And so kind of highlighting we need better ways to be able to really identify individuals that are actually at risk versus ones that we don't really need to worry about these mutations. And so this is kind of the impetus for our project. Really, we know the genomics, we know epigenomics, environment, they all contribute to the proteome. And we really wanted to use kind of the proteome as this downstream signal that kind of integrates all of the signal to see if there's additional predictive ability that we could identify. And we know the protein is really what's directly related to the function in the body as well as kind of biological phenotypes. And so our hypothesis for the project was that there's signal in the blood protein levels that before people develop a myeloid neoplasm that we might be able to risk stratify based on those. And so we turned to the UK Biobank for this study, and I just want to talk a little bit about it because it really is kind of seminal for this study and really is a unique one-of-a-kind resource that allows this type of epidemiological study to be possible. So the UK enrolled 500,000 individuals. At the time of enrollment in 2006 to 2010, they were aged 40 to 69, overall fairly healthy people. And then they've watched those over time. They have to see what kind of health outcomes these people have. And so this whole cohort we have now over 13 years of follow-up, which is really great. It has really rich sources of data, both clinically from kind of EMR as well as key for our study, death and cancer registries, which we can use to really accurately identify the development of myeloid neoplasms. Additionally, there's genotyping data, now whole genome sequencing, and key for our study is the presence of whole exome sequencing, which we're able to, from the peripheral blood, which we're able to look at to identify the individuals that have evidence of clonal hematopoiesis. Lastly, that's really kind of made this project feasible and was the impetus for it was in the past year. Last year, in the middle of the year, they released O-Link proteomics data. It's a targeted proteomics platform that analyzes about 1,500 different analytes in the peripheral blood. And these are really proteins that are selected for known roles in human disease kind of focus. And so just to briefly kind of give an explanation, this is different than like mass spec that some folks have heard of. It uses really a dual antibody recognition approach. And so you have two different antibodies here on the right, two different antibodies that bind to separate epitopes on the same protein. And each antibody is tagged with an oligo. And when those oligos become in proximity to one another, they're able to undergo hybridization, which creates a DNA barcode that can be used to quantitate the amount of the protein level by sequencing. And so kind of an overview of our kind of study schema that we used for this analysis. And so we identified that there were 46,000 individuals with no prior diagnosis of a myeloid neoplasm that were randomly selected for this O-Link analysis of the plasma proteome levels. And of key, these were plasma proteome levels that were between 2006 to 2010 at the time of development, and then we watched them over time kind of through the death and cancer registry records to able to see the individuals that developed a myeloid neoplasm over that time period. Overall, 115 individuals developed that, and then we had 46,000 of our control arm that didn't develop a myeloid neoplasm. And we used these as our two comparison groups to try to identify was there any protein signal associated that would kind of predict who would develop myeloid neoplasm. For our analysis, we used a Cox proportional hazard model, and we really, for each protein fit, the protein expression based on kind of that outcome of interest of development of a myeloid neoplasm, which was kind of that composite of all three different types. The MPNs, MDS, and AML. And with this analysis, we controlled for basic things like age, sex, ancestry, smoking, blood counts, and collection wear, which are all known potential confounders in these types of studies. Overall, in the analysis, we identified 115 proteins that were significantly associated with myeloid neoplasm risk after FDR correction. And that's represented here in a volcano plot. And so overall, on the x-axis, we're depicting relative protein expression. On the y is the FDR, the significance level. And then we also have kind of highlighting some of those top proteins. Really, to gain insight into this big list of proteins, we performed gene set enrichment analysis using the ractome pathways. And really, the top pathway that our genes were involved with was this immune regulatory interactions between lymphoid and non-lymphoid cells. And given this is a panel of there's cardiovascular outcomes, or cardiovascular related proteins, there is neurological related proteins. We thought that kind of fit with likely the kind of the primary dysfunction in this process. And so it's really hard to find another data set to try to externally validate this and really to make sure what we're seeing is real. And so we had to kind of turn to an alternative approach of using kind of genetic association or polygenic risk scores to be able to try to validate this signature. And so kind of here is showing kind of the construction of these polygenic risk scores, but essentially we take the data we had before and we add the genotyping array data to it. And so then we're able to use that to identify SNPs that predict protein expression. And we call those are called protein quantitative trait loci. And then if you pool those together for each protein, the different SNPs that account for its expression levels genetically, you're able to generate these polygenic risk scores, where you're able to get genetically predicted higher levels of expression versus lower levels of expression. And so we generated these polygenic risk scores and then wanted to apply them to the cohort of the UK Biobank of the 380,000 people that we didn't have any plasma proteomic data on. So all of these patients were not analyzed in our first analysis. We used their genotyping data that was available to then take our polygenic risk scores combined with that and really predict the genetically predicted protein expression for each individual and repeat this analysis. Genetically predicted protein expression is overall the effect size is smaller, So the one advantage we had with this analysis is we were able to have a lot more individuals that developed a myeloid neoplasm, given a much larger cohort of almost 1,000 people that developed that. And so the results are shown here. We had sufficient statistical power to assess 110 of the myeloid neoplasm risk proteins. We found that 10 of those were significantly associated, and of those, 59 were directionally consistent. And on the right, or I guess, yeah, your left, sorry, on the plot, you can see in the hazard ratios, we have the top 10 genes that were the most significant, with hazard ratios less than 1, meaning decreased risk, and some on the right where increased expression was associated with increased risk. I didn't have time to go into it today, but we did some other Mendelian and randomization studies and didn't find any evidence that really that these proteins were acting in a direct role. That mostly the model that I have kind of here is that we have upstream pathways that are associated with the proteins that we're identifying that are also the ones that are more causative of the increased risk of myeloid neoplasms in this population. And so last, we really wanted to try to apply this clinically and think about could this potentially be useful. And so we really turned to a machine learning approach here. And so we used lasso regression with this data set to really identify the most predictive clinical, proteomics, and CH features that can predict the risk of myeloid neoplasm, and then use it a nested cross-validation approach to really compare models either containing the proteomics features or without the features. And so shown here is the ROC curve to really kind of assess the model. And so at baseline, just using basic clinical parameters, we see an area under the curve of 0.73. And if we add the proteomics features, we see a moderate improvement or discrimination with an A1C that increases to 0.81. This is pretty comparable to the signal that we're actually able to detect from identifying the presence or absence of CH in these individuals. Additionally, when we incorporate all the differing features in the model, there is some of that signal that the proteomics is adding on top of the presence of CH as well. And so based on, didn't go through, we really wanted to really understand this a little bit more. Yeah, I mentioned at the beginning, the CHRS has been developed, and it's a risk score for looking at some of these basic parameters and saying how risky are people for progression. That's that Kaplan-Meier curve I showed at the beginning of the plot. And so when we did that for all the participants on the graph to the far left, you can see that we saw that when we add proteomics features to that CRHS score, it actually has a better predictive ability. So we have this moderate improvement in discrimination from an AUC of 0.79 to 0.86. We did some sensitivity analysis to truly kind of better understand this, and we broke this down by individuals who were considered to have no or low risk of CH versus individuals with medium and high risk CH. And we're really able to show that in this analysis that we were really able to see most of the benefit was in this no and low risk CH population, where we had an AUC improved from 0.71 to 0.8 in this no to low risk CH. But in the population, the medium and high risk, where we're already pretty good at risk stratifying these individuals, we don't really add any signal with adding the proteomics. If anything, the model was basically the same, and actually the area under curve was slightly worse. And so overall, we feel that really we're able to detect some signal here, and that there may be some clinical utility in the right clinical context for risk stratifying patients. And so really to kind of put this together and for the talk of really, we've identified that plasma proteins, even years ahead of diagnosis, can predict risk of myeloid neoplasm. In work I didn't show you, we show that really this is only partially mediated by the presence of CH at the time, and that most of these is not really a directly causal role of these proteins. We're more picking up a signal from some upstream pathway that is reflecting both. And lastly, that the plasma proteomics really is able to improve prediction beyond just currently used clinical and CH features, and might be particularly useful in the individuals that have the lower risk CH to really help risk stratify those people moving forward in the future. And so acknowledgements, just like to thank everyone here. I think I already went through that, but I think the last kind of group to really thank would be the Mentors in Medicine group, Dr. Gage and Dr. Eisen for giving me the opportunity to speak, as well as Dr. Frazier and Dr. Cheng for the continued support of the program and really giving us a lot of time. And then lastly, really thanking the individuals in the UK who volunteered their data, their personal health information, essentially to really allow a lot of progress scientifically in the past decade.
I'd like to thank all four speakers to come up for the Q&A period. Dr. Eisen and I want to thank some people that made this program possible, beginning with the Farrell Family Foundation. So the Mentors in Medicine program, we give out about $100,000 per year, and so we're very grateful to the foundation for supporting our mission. Dr. Eisen and I are also very grateful to Ann Ahrens, who really runs the program and takes care of the day-to-day activities. All the mentors that participate in the program will take a photo with the mentors, and all the judges that participated in the poster session and helped us evaluate the proposals. So speaking of the poster sessions, I do have the winners from last week's poster session. And in third place was Raul Paravalli. Congrats, Raul. And then tied for first place from last week's poster was Rakna Raghupathy and Lekha Panja. So congratulations. There is a monetary award for the poster winners. There will also be an award for the oral presentation. So please, all the speakers come up. We've got a few minutes for question and answers. And Vincent, maybe I'll ask you the first question. I was just curious, with the change in UNOS, do you think that the reason the risk scores don't work is maybe the clinicians are sort of using the risk score in terms of selecting patients and triaging their therapy?
Oh, now it's working. Yeah, that's a great question. So I think it's just part of the advanced therapies evaluation. You know, if someone is clinically ill enough to be listed for a transplant pretty much immediately, or if there's a little more room to use different devices. HeartMate-3s are very popular right now, so I think and it's pretty much the only one that's used, as it's magnetically levitated and it's just structurally a better device. So I think when they're kind of using the score, it's really to determine should they get an LVAD, or should we start considering other types of advanced therapies? So it's hard to say, but I think our kind of concern is that since the UNOS tier system changed, it's the entire patient population and eligible pool for HeartMate-3s was likely different too. And we do think that is the case. It's just kind of yet to be determined what makes them that different. So.
Other questions for the residents? Yeah.
I have a question for Dr. Kwok.
Okay.
So, terrific presentation. You know, just at a practical level, as a clinician, I always find there's clearly elevated risk for anyone with a systemic inflammatory condition, right? Rheumatologic conditions, under-recognized cardiovascular risk. So I wonder if it wouldn't work just to calculate the risk score and then add a level for these people. Like, just give them an upgrade from 2 to 5 to 5 to 10 because they have a systemic inflammatory condition.
Are you saying to do that, or are you wondering?
Yeah, just as a clinician, like in the office, right? Rather than develop a risk score for lupus and a risk score for HIV and a risk, just like inflammatory disease, they're higher risk, given up an upgrade.
That makes perfect sense. I will probably defer to you because you're an expert in the field. Yeah, I think HIV just was listed as a risk enhancer for cardiovascular disease. I don't think my project would be able to quantify how much additional risk there would be in terms of percentage points, but I think that's like a good thought. I don't know. I'm not sure.
Yeah, I did when I was a resident, I did a talk on lupus, very much like yours,
Yeah.
analysis.
Yeah, yeah.
So lupus does the same thing.
Yeah.
Like,
Yeah.
they get their cardiovascular disease in their 40s, not their 50s.
Right.
Yeah.
Yeah.
So I'm going to ask the speakers to stay up here for Q&A, but the time is up. Also, we're going to take a photo, so if your mentor is present, please ask your mentor to come down. Thank you, everybody, for your attention.